who've already started using the comments section. Thank you. So we'll come back. If you want to make comments as the guys go along through the slides, we'll come back to them later. I'm really grateful to Lynsey and Cate, who've put this session together really quickly. And thanks also to Shevonne, Matheiken and Andy Roney for their input as well. This teaching has come out of concerns raised by trainees. We're hearing lots of really valid concerns about COVID, about looking after our patients correctly and looking after ourselves. And it's quite right for you to raise these issues, and we want you to continue doing so. But clearly, obviously, not all of those questions are going to be answered today in one session. There'll be plenty more learning in the coming weeks, plenty more opportunities for discussing other scenarios in future sessions, if that's useful. We're all obviously involved in helping to solve the problems and challenges that are raised by the virus. So this discussion is really a starting point for sharing some learning and helping us all to feel a bit more confident. So I'll pass over to Cate and Lynsey to start the case off.
Okay, cool. And I suppose the other thing to say is that there will be an opportunity as well for you guys at the end to sort of have a think about other cases or situations that you might be encountering, because we want to try and keep, I suppose, responding to the issues as they arise. But if you can just kind of hold those ideas in mind as we go through, because I'm sure you're encountering a lot of situations, and as Juliette said, this is really just sort of the first thing that we thought of. And I suppose the other thing to say is that the way we've thought through this is also dynamic. So that's why we'll be asking for your participation. It's not a guideline, because we're not yet able to write guidelines about these kind of things. But so it's just a way of thinking through something that you're probably encountering already. So please do kind of participate with your thoughts and so on. So we'll just get started. Sorry. Yeah, so just to begin, so this is a case of someone who's a 49-year-old man who's got diagnosis of schizophrenia, and we're imagining that you guys are the night SHOs on call and you've been asked to see him. He's under Section 2 and he's had a relapse of his psychosis. And he's told the nurses that he's feeling tired and sweaty, and they've taken the OBS and he's got a temperature of 37.9. And he was admitted 2 weeks ago, restarted on clozapine, and has recently returned from 3-day leave. So what I want you guys to think about, I'm sure you've already kind of approached situations like this. I'm wondering if you can kind of give us some ideas about what information you might want to try and gather before you go and see this person, how you might go about that, who should you be calling at this stage, if anyone. So feel free to kind of type some ideas in, and then Lynsey will kind of read out anything that comes up.
All right, so we're getting some comments here. Contact GP, recent blood work. Clozapine compliance, that's a very good point. Any other thoughts, guys? All right, lots of good suggestions coming through.
Everyone can see those, can't they?
Yeah.
Yeah, so just to remind us, we've got a man who's 49 years old, he's got schizophrenia, he's under Section 2 and he's had a relapse of psychosis. He's been in hospital for 2 weeks, but he's recently had leave, and he's now tired, sweaty, with low-grade fever, and he is also taking clozapine. Yes. Do we need to read them out? Or can
I don't think we need to read these. You can all see these comments, can't you guys?
Need to see.
You should all be able to open a comments box on the screen. All right, well, let me read some of them out then, since some of you are not managing. So we've got a couple of people asking about clozapine compliance, people asking about exposure to COVID and whether there's anyone in the family with symptoms of COVID. People are also interested in respiratory history. What else have we got here? Any other specific symptoms that point towards any particular organ systems involved in infection? Traveling history, systemic symptoms, other antipsychotic medication. Yeah, lots of good suggestions in here.
Okay. Cool. All right, shall we move on?
Yeah.
And a recent FBC. Excellent.
Oh, yeah.
Love this. Okay. So this was kind of what we thought was a reasonable start. So I suppose, as with any other time that you receive a call from the ward, you're going to want to find out really how unwell is this person right now, so that then you know how much time you have to go and look up all of these things, or whether you need to tell them to be calling an ambulance or calling the medical emergency team straight away. So obviously that's a bit of the kind of phone triaging that you do all the time. So asking for other observations, because you may only be presented with one. So what is the pulse, respiratory rate, blood pressure, SATs, and conscious state. And we're going to talk a bit about news shortly, but essentially if it's kind of around 4 or more, you're potentially wanting to kind of call for an emergency assistance more quickly, because well, we'll look at the news chart shortly and look at the different responses to that, but that will dictate how quickly you need to get there and whether you need other help. And the other thing is to try and get someone to get the PPE ready, because that may take a while. So giving someone a heads up that you're coming and you're going to need PPE is a helpful thing to do. So essentially, if the observations are kind of all mildly abnormal or within the normal range, then that obviously gives you a bit more time. So you can ask them more questions of the nurse on the phone about, you know, how the person seems generally, if they got any other symptoms, how are they in terms of their mental state, and any risks, which you also need to know before you go and assess this person. What is it? So just a revision of the kind of news score, which we're generally using on the wards.
So
do you want to address that comment?
So there's a question coming in here saying that if we ask for PPE, will this not worry the staff? That's a good question. I mean, how do you guys think you would handle that? So people are saying, will it worry the staff if we ask for a PPE? And how are you going to handle the anxiety that staff might feel about you asking for PPE?
I think I would be saying the advice on the phone is also that they should be wearing PPE. We imagine that someone's already taken a set of obs at the time to reveal this temperature, but from then on really, and we'll get to that in a sec, but from then on really they should be using PPE really anyway, and that's what we're about to kind of tell them over the phone as well. So yeah.
But I think ultimately being calm and explaining your rationale and just not adding to any anxiety is pretty important.
Yeah, definitely. So just to go back to the news score, and this is the kind of rationale for why it's helpful to have all of the observations and to kind of have a look at it in light of news. Partly because it's a kind of very robust early warning system, but it also gives us kind of grounds to call for help if needed. So we can score this guy on the chart, which I'm just trying to think, I can't remember his obs now. But basically he's scoring less than 4, so he's okay for now. But just to explain, what is this? Anyway, to explain why we're kind of looking at the kind of 4 or below. When we look at the news, it's kind of made for an acute medical ward. So it's kind of, when they're talking about ward-based response, they're sort of talking about a medical ward-based response. And when they're talking about an urgent ward-based response, again, they're talking about an urgent medical ward-based response. So, you know, when you look at the kind of response that they're expecting, clinician or team with competence and in the assessment of acutely ill patients, recognizing when escalation of care to a critical care team is appropriate. So we don't necessarily want to be kind of messing around trying to figure out if someone does or doesn't need critical care. If they're potentially likely to, we want to kind of get people on their way.
We've got a question coming in about how are the stocks of PPE at the moment, and Dr. Gouli's just told us that PPE deliveries have arrived now and are not going to be locked away, but we can come back to that later.
Yeah, and just to say that Dr. Gouli is going to speak for about 10 minutes at the end of this, so you can keep all of your hardest questions for him. That one. So essentially, So this patient is stable. So he's got a new score of 2. His SATs are 96%. His blood pressure is 115 on 74. Pulse is 116. Temp 37.9, respiratory rate 18. And he is alert. He's speaking in full sentences, but he's feeling pretty rubbish. So what should we do next? Does anyone have any ideas on what needs to happen now?
So some suggestions coming in already. Some people are saying we need to examine him in person. And some people are asking about whether we should do respiratory isolation straight away, which is something we can start thinking about. A lot of people saying isolate him and or examine him.
Yep.
And people highlighting that they're going to put on their PPE first before they examine him. Okay.
Okay, great. So generally the vibe is we need to kind of assess him further and probably isolate him and be wearing PPE ourselves. So I think that's kind of the general vibe. So as we said, we're already kind of asking for some PPE. We're asking a member of nursing staff to kind of keep him in his room and remain outside. And then we want to try and confirm the details for the patient, and then we've got a little bit of time to go back and look up some of those things that you were talking about before. So, you know, what's his general health like? Is he smoking? What medications is he on? Obviously, particularly clozapine is one to be particularly concerned about. We're looking at all of his medical history, all of the things that would make him kind of high risk for a serious illness. But also, you know, the other thing that we need to remember is that people are going to get sick with all of the things they normally get sick with, apart from COVID. So actually understanding his medical history is also quite important. So we want to know about drug and alcohol history and that sort of thing, and also risk assessment, because we're about to be going into a closed room with this gentleman. And as people have pointed out as well, kind of bloods and previous observations. Do you want to respond to any comments, or I think we'll...
I think there's a few comments coming in, but I think we can respond to them a little bit further down the case scenario.
Yeah. We go back. Oh yeah, no. So this is a bit more background about Mr. J. So he's got long-standing schizophrenia, but he's been doing very well since he started clozapine about 5 years ago. No admissions up until this most recent one for about 5 years. He relapsed after he stopped his clozapine. He stopped it because he was worried about increased risk of corona, and he relapsed quite quickly. He's got type 2 diabetes, he's overweight, he's got high cholesterol, and he's a current smoker and has continued to smoke during this admission. Hasn't used drugs and alcohol for many years. When he's unwell, he can be a bit paranoid, suspicious, mistrustful, sometimes gets paranoid about MI5, but hasn't been physically aggressive for more than about 15 years. The report from the nursing staff that know him well is that he, since restarting clozapine, has been pretty much back to his usual self. He's very likely to be discharged off section soon, and he's recently had home leave for 3 days. He's taking clozapine, senna, hyoscine, metformin, and atorvastatin. And he's had pretty unremarkable observations in the last few days, so pulse around 100, normal BP, no fevers this admission, and his last clozapine bloods and ECG were taken 3 days ago and they were normal. So his neutrophils were fine as of 3 days ago. So, how will we prepare to see Mr. J? So some of this stuff has already been raised already in terms of him being in isolation and us wearing PPE. So if there's anyone who's got any kind of other ideas about what we need to do before we go in and see him. I think that's a good idea, is kind of bringing things to nearby.
Yeah, to minimise the number of times you're going in and out of the room to get phlebotomy equipment, for example.
Yep. Cool. Yep. So as you kind of already gathered, so you're going to wash your hands, you're going to put the PPE on as advised. We're going to go through that in a sec. And then obviously that, depending on the risk assessment, we're going to consider seeing him with another member of staff also wearing PPE. In this situation, given that he's quite low risk, we'd probably go in on our own rather than exposing someone else as well. And as people have pointed out, having some things kind of just outside and someone to kind of act as a runner and kind of pass things to you if needed is a really good idea. So putting on PPE, just to explain, so when we're needing to go within a metre of someone with possible COVID, it's the fluid repellent face mask, apron, gloves and eye protection if there's a risk of splashing. So that's the kind of surgical masks. And this isn't probably going to be an aerosol generating procedure, so we're not talking about the other type of masks at this point in time. We can go on. So then this is again just the government advice on kind of what type of things we need at the moment. And I think there's some other good ideas coming up here about getting the orange bag ready at the door to dispose the PPE. And also a really nice comment about reassuring the patient, because I think that's the other thing that there's a lot of anxiety and it's pretty intimidating.
Yeah, pretty frightening.
Yeah. So just to say, the links for everything are at the bottom of the slides.
This is from the gov.uk website.
Yeah. Onward. So in terms of putting on PPE, I realise this is not entirely the PPE that we have, and we've got just the apron, and then we've got the surgical mask, the eye protection and the gloves, and essentially you put things on in this order, you take them off in the reverse order, so we'll go through that as well, but washing hands before putting the PPE on. So as we said, essentially in terms of the isolation, it's going to be kind of keeping him wherever he is at that time. So he's in his room at the moment, we want to keep him in his room, we don't want to be walking him around on the ward or definitely not moving him to the examination room. So keeping him exactly where he is for now.
So that being said, if he was in the examination room, just keep him in there.
Yeah. So as we said, explaining kind of, why you're wearing the PPE and trying to reassure him. The other thing maybe to say is also that you're probably going to try and spend not very long with him. So not to kind of, I guess to explain that you don't mean to be abrupt, but you're not going to spend too long because it's actually good to minimize the amount of time. So maybe just, it's almost like doing a cask where you have to say that thing where you're like, I've only got 7 minutes. I don't mean to be abrupt, but I'm going to kind of close down some of your questions potentially.
Love to see this as a cask scenario in a few years' time.
Yes.
We're all looking back and laughing.
Yes, yeah, definitely. So as a lot of you have pointed out, is also that we need to remember that, we need to approach this person as someone who's got a fever. We don't know exactly what's causing that at the moment.
Yeah, we have to be very careful to avoid any diagnostic overshadowing just because we're so anxious about COVID.
Yeah. So what should you be looking for and asking him, given that you've got not many minutes? What kind of focus, history and examination would you be wanting to do?
So lots of people asking about cough, checking for shortness of breath, heart sounds, DMV. Wow, we're getting these are a lot of suggestions all at once. Checking SATs, feeling his tummy, looking for any upper respiratory tract symptoms, checking vital signs, doing a urine dip, listening to the chest, especially the base of the chest.
Someone also pointed out, has he taken his clozapine as well?
Yeah, good question. People also saying look at the legs, look for signs of cellulitis. Asking him about contacts with COVID patients.
Cool.
All right, wow, lots of comments coming through, lots of really useful ones.
I wish you guys were around every time we did on calls.
Oh my gosh, if we could just do all our on calls by consensus, we'd do really well, wouldn't we?
Yeah, and abdo pain as well. So yeah,
absolutely.
Okay, onward. So I guess, it's also about the general impression that you get. So just what does he look like? If someone looks sick, obviously you guys, I know it's been a while necessarily since you've done kind of acute medicine, but the thing that you did learn in your foundation years was like how to spot a sick person. So hopefully you're still quite good at that. and trust your gut instinct. So then if the person's unstable, that's when you're needing to call for help. At that point, you'd probably repeat the observations. And if you've got a bit of time and he seems to be stable, you're going to kind of take a focus history. And I suppose the difficulty in this situation, I don't know the answer to this, is kind of how much time you spend asking about all of the symptoms that could be associated with fever, or just the ones that are going to kind of change your management. I think in terms of what I thought of that are going to change your management potentially, or send you down a slightly different direction, chest pain is one. Again, could be associated with COVID, but in someone taking clozapine, it's going to potentially send you down the kind of myocarditis route. Dysuria, maybe that's a urine infection, but again, you probably wouldn't rule out COVID just because someone's got dysuria anyway. Neck stiffness, rash, photophobia, obviously sending us down a kind of meningitis type route. And cellulitis, obviously, if you can see something. Lots of people talking about loss of smell and taste.
Yeah, do we want to address that?
There's the evidence is mixed at the moment. So
basically there are some sources saying that loss of sense of smell is a predictor of COVID. There are other sources saying that actually it's not a very good predictor. So at the moment the evidence isn't really pointing us one way or another. So it's probably not a very helpful question to be asking.
Yeah. So I guess the jury's still out really, but I think there's a good point being made about kind of how far away you stand from the patient. So I think that's also, it's worth doing, and also worth saying to the person, I'm going to stand a bit further away so that they're not thinking that there's something wrong with them. Because especially if someone's already a bit paranoid, you turn up in your PPE and then you're like refusing to go anywhere near them. That's likely to kind of rub people up the wrong way. And obviously dyspnea is another thing in terms of kind of severity, and kind of general physical health. We've talked about exposure, so that's a good thing to ask. And so as we've kind of been trying to talk about, you know, you have to kind of cast quite a wide net, given that there are loads of different causes of fever. You can probably think of more than we've even kind of thought of here. But again, the ones that are particularly relevant to this man are sort of the potential for febrile neutropenia because he's taking clozapine, and actually generally just other infections, because we know that people who take clozapine have a higher risk of a load of other infections for various reasons. And even, I suppose, the problem with this time is that even if we think we've kind of located a particular kind of cause for a fever, say someone has gastro symptoms, we're still going to have to isolate them as a possible COVID case because, you know, people get gastro symptoms with COVID, but also we're going to have to kind of treat it as possible COVID until we get a negative test anyway. So,
and that being said, if someone does have gastro symptoms, you would want to isolate anyway. We don't want the staff catching gastro and having to take Zymotic.
Yeah.
So.
And also obviously we want to consider the other kind of non-infective causes, so NMS in someone who's taking antipsychotics, again myocarditis in someone who's taking clozapine, and again, you know, most of you probably know that that can present quite atypically. The first person I ever saw who had myocarditis just had diarrhea and was really worried about his diarrhea, and it wasn't until I examined him that I found that he was tachycardic, and then endorsed kind of pleuritic chest pain, but only on direct questioning. So people, especially if they're kind of unwell psychotically, can kind of present with quite vague symptoms. And then other things that can kind of masquerade as this, you know, in terms of alcohol withdrawal or intoxication. And again, if someone's tachycardic, we have to think about PE and MI in people, especially who take antipsychotics and have loads of kind of cardiovascular risk factors. So just a little bit, I guess, I made this slide on Monday, so things could have changed since then because we know that COVID time is faster than normal time. It's great, we're all living multiple lives in the time that we have. So, you know, you probably are aware of all of these things that we've kind of known about this since kind of December 2019. It's a respiratory infection. It can range from a kind of mild common cold to severe viral pneumonia. And the times that we want to sort of think about this is if someone's got a new continuous cough, a temperature or dyspnea. But again, we know it can present with various symptoms. And onward. So again, it kind of resembles a viral pneumonia. When they're talking about mild illness, I think there's been some criticism of this term mild, because actually it's kind of mild that doesn't require hospital admission, but it's not mild in the sense of it doesn't affect your life. So anyone who's had it or is at home now who has it currently will be able to attest that it's actually quite nasty. And obviously we need to be worried about people who are immunocompromised or older. And I suppose, as you're also aware, that, you know, many of our people who are in their kind of 40s and 50s who've had chronic psychotic illnesses, who are kind of taking antipsychotics, who've had pretty tough lives, who are smokers, are actually probably frailer and older than their years, so, you know, are at high risk of getting a severe illness. And what we know from China is that people who tend to require critical care are those who are over 60, have comorbid conditions and so on. So those are the symptoms. I think we can probably keep moving on. And mild illness defined as someone who's kind of got an uncomplicated upper respiratory tract infection with non-specific symptoms.
There's some questions coming in about keeping the door open or closed if we are isolating someone. And I think generally speaking, the advice is to keep the door closed. Just to clarify that.
But just to remember that there is lots of information on the Trust website under infection control, and we can probably answer some of these questions from that a bit later.
Sure.
So people is already kind of coming up with some ideas about examination, but maybe if you kind of can type in with what you're thinking of looking for on examination. No.
So lots of suggestions coming in. People want to look for hypoxia, chest sounds. Gosh, so many. Increased respiratory rate. Some people suggesting an ABCDE approach, and lots of people mentioning cough. Okay. Some suggestions around abnormal lung sounds, and people suggesting that we look specifically at the bases of the lungs, looking for crackles.
Yep. So just starting, I suppose, at the head, thinking about kind of orientation and cognition is kind of important to be aware of, again, because we're seeing some reports coming out of kind of COVID being related to delirium in older people, but again, for all of the reasons that we've just talked about, you know, our patients are potentially at higher risk of delirium. And again, that's kind of all of the things that you're sort of saying. So as you would routinely try and examine, but a focused examination for someone who's got a possible infection. So, you know, their general appearance, their respiratory rate, speech, and that sort of thing. Obviously, you get quite a good idea of whether or not of someone is kind of well or ill based on kind of whether they're able to speak to you clearly or not. I'm going to respond to that now.
So yeah, so a question coming out about whether chest craps are typically expected or not in COVID. It's a good question. I think that what we're hearing is that you tend to get peripheral lung sounds, if anything, in COVID patients, but it's certainly not an absolute definite, and it doesn't exclude the diagnosis if you don't have any chest sounds.
Well, I've seen some people saying that you won't necessarily hear anything. So I guess, you know, especially for people who are psych trainees, if you're not confident with your skills as well, like I certainly wouldn't be confident about whether I was hearing things or not. So just obviously escalate if there's any concern. This is the basic.
Yeah, also a really good point just coming in here around how stethoscopes can be a major source of spreading infection. Please sterilise your stethoscopes every time you use them. All right, should we move on?
And I think the reason that we might be still listening to this person's chest is more because we need to decide whether we need to do any further investigations, and we're probably going to be speaking to the medical registrar, or potentially, so kind of deciding about whether or not we send this person from this ward into the acute hospital or not. So just having enough information to be able to have that conversation and not having to go back in and out of the room. But you know, I think that it's I don't know the answer to that. I think I would probably try and listen to this person's chest, but you know, again, it is up to you guys what you feel. But yeah, definitely sterilized stethoscopes.
Yeah, I think I'd be inclined to listen to the chest as well. I think it kind of helps inform the decision a little bit about what steps to take next. All right, shall we move on?
So this is the BMJ guidance in terms of assessing someone. So this is the kind of findings that they talk about in terms of inspiratory crackles, rails. Does anyone still call them rails? Anyway, bronchial breathing. But again, you know, some of the things that are coming out more on Twitter with very acutely unwell patients is kind of like Juliette said, that sometimes they can have no sounds at all, but they're about to go into respiratory failure. So, you know, I think it's still unclear. So what he's told,
Mr. J,
yeah, back to Mr. J. So he tells us that he's felt really tired since yesterday, feverish for the last 24 hours, and now has a dry cough, muscle pain, and he's not hungry. He's got no dyspnea, no hoarse voice, none of those other things. So he's got no chest pain, no diarrhea, and any of those other signs. He says that when he was on leave, he spent time with his friend in supported accommodation, and this friend now has fevers. So his OBS are much the same as they were. So his SATs are 96, blood pressure is still stable, he's still a little bit tachycardic and still has a low-grade fever. His chest is clear, heart sounds are dual, no murmurs, belly soft, no signs of cellulitis or rashes, and he is neurologically intact. So what do people think is going on with Mr. J?
We'll give you guys a minute or two to come up with a differential diagnosis on the chat box.
So we can just go, just a reminder of what his findings are. So lots of votes for COVID, from generally mild, possible myocarditis, influenza, yeah, okay, so yeah, this is kind of what we came up with. So we pretty much kind of covered all of those. So we've got, that's our list at the moment. So then it's like, how are we going to kind of rule in or rule out any of these things? So what next? So the question, I guess, is, does he require an acute hospital admission? Do we need to be transferring him? What other investigations do we need to do, and who should we be speaking to about this? So in terms of the does he require an acute hospital admission, this is it's a tricky one. So WHO think that anyone who's got a laboratory confirmed case of COVID should be isolated and cared for in a healthcare facility. Obviously the idea of a healthcare facility is anything from our ward to the Etihad Stadium. You know, we don't know where people are going to be in their healthcare facilities. And obviously it has the caveat that things need to be prioritised. So people who have a high probability of poor outcomes, however, should be prioritised, age more than 60, underlying comorbidities. But again, still might not be possible because of burden on healthcare. So they talk about how home care can be considered as long as someone can be followed up and cared for. And I guess, I don't know how we would define the mental health ward, but I guess I would think you need to be kind of well enough to be at home to be managed with COVID on a mental health ward, if that makes sense. But that would be a discussion to have with others as well. So in summary, he's a 49-year-old man with schizophrenia. He's mentally stable currently. He's alert. He's taking clozapine. He's got diabetes. He's overweight, and he's a current smoker. And he's got myalgia, sweats, fatigue, dry cough, anorexia, raised temperature, and heart rate. And he's had recent contact with another symptomatic individual and he's got possible COVID, but we need to rule out other clozapine related issues. So I'm just thinking, so there's some comments about kind of whether he would benefit from transfer because of his kind of risk factors. And I think that's, for me, the reason that I would be speaking to the medical registrar, at least just to discuss him, even to have him on their radar, because, you know, I think he actually does have a number of comorbidities that increase his risk for kind of quite a severe response if he were to have COVID.
Yeah, and a very rapid deterioration if he does.
And also to discuss really kind of what investigations we should be doing, because we don't want to be ordering things that we shouldn't, but also we want to kind of be aware that he is also taking clozapine, and we still need to kind of rule out clozapine related issues. So he's going to need to have some bloods anyway, because we can't be giving him his clozapine again until we know that his neutrophils are okay and he hasn't suddenly dropped them. So these were the kind of bloods that we thought about, but I guess the thing is that the BMJ guideline for possible COVID and kind of assessment has a load of other tests with kind of LDH and procalcitonin and things. So we want to probably discuss with the medical registrar about what and what not to order, rather than just kind of take a sort of scattergun approach.
Yeah, especially since those recommendations are quite likely to change, you know, very quickly over the coming days and weeks.
Yeah, and also, as you put, getting in touch with infection control is really important as well for advice.
And we do obviously want to try and do a COVID test, so that would be discussing with the infection control as well. Some comments about MedReg not being able to call you back. I mean, I think we have to be realistic that they're not going to be able to call us back straight away. And this man isn't unstable, so he's not someone that they need to drop everything to discuss. We can probably take some bloods, you know, and kind of start managing it ourselves. But I suppose the things that we need to ask of them is whether we need to send him for a chest X-ray at this point in time. The answer is probably going to be no, but you know, we don't want to just kind of send him on his way over there. I think if we don't at least try and discuss with someone who's got specialist medical knowledge, we would probably be doing a disservice to this man who's very high risk, and given that he's going to be under our care, probably at least worth kind of trying to contact.
Yeah, and there is infection control out of hours. There's also your SPRs, your consultants. You know, do draw on the available help. Don't just make decisions sort of on your own.
Yeah, I mean, we're all going to be learning a lot more about this in the coming weeks, so do reach out to your colleagues to find out more about what they've learned.
And if you haven't already spoken to your SPR, or if you are an SPR, you might want to call your consultant. I imagine that everyone would be happy to be contacted. I think just particularly because we're going to be discussing about clozapine, and we're also going to be discussing about where this person's going to be cared for. So I think that's kind of important to discuss with senior people. And as people are saying also, in terms of kind of depending on what the picture's looking like, you might be wanting to speak to cardio, depending on whether he hasn't got chest pain. But if he did, you probably would want to, and you probably do an ECG as well. And again, the logistics of that are a bit tricky, but I suppose kind of having potentially getting someone to bring the ECG machine to you. There's a whole load of things to do with cleaning of that after it's been done, which again is something to discuss with the infection control team. So when we finished hopefully everything that we've done with him in the room, we're able to kind of take our PPE off according to the advice that we have. We need to then have those phone conversations with DSN, infection control and nursing staff about where this person is going to be nursed as a kind of potentially COVID patient, but bearing in mind that we're not going to have an answer to that. Even if we swab tonight, we're not going to have an answer of that in, you know, at least kind of 72 hours. I think some of you are already kind of discussing about frequency of physical obs. I would say probably minimum of QDS in someone that we're quite worried about deteriorating because of his risk factors. Obviously the leave needs to be cancelled, so that's kind of also an exercise in breaking bad news and kind of explaining the reasons for that. and the reasons for the isolation. At the moment, there isn't any, if, you know, again, we don't know quite what's going on with him, but if he's got COVID, there isn't really any treatment at this point in time. If someone was to be admitted to an acute hospital, they might be given antibiotics, but not in this situation just yet. He's going to need nicotine replacement because he's a smoker, and paracetamol PRN. At the moment, you're probably aware of all this guidance about ibuprofen, and kind of the risks of that, or the potential risks of that. What we seem to see is that, you know, the BMJ again at the moment is kind of saying if someone's already on an NSAID, you shouldn't stop it, but definitely don't start it for someone just with like muscle aches and that sort of thing. And paracetamol should be given if someone's got fever and pain, not just for fever. So onward. Yep. So that's just about the doffing PPE. As I said, it's kind of the opposite order of, or the reverse order of how you put it on, and again, kind of putting it in the safe bin.
And washing your hands immediately afterwards as well.
Yes. So the things that we're thinking about in terms of other considerations, obviously this is a complex case, but it could be even more complex. Some of you have already talked about kind of what happens if he's resisting, and that might be something that we have to talk about next week. But so talking about continuing medication like clozapine, there isn't much advice on this, but essentially we need to be aware that this can kind of mimic a febrile neutropenia, so someone does need FVCs. It's likely that you might need to, depending on what time it is, withhold his at least one dose until you can get the FBE back. But again, that's the thing to be discussing with your SPRs and consultants. We know that people who are taking clozapine are at increased risk of a load of kind of infections. This is because of various immune factors, hypersalivation and smoking. So he could be at risk of just a viral pneumonia anyway. And also stopping smoking is going to increase his clozapine levels, and that isn't replaced by nicotine replacement, so we need to kind of keep an eye on his levels or think about potentially reducing.
That being said, we're having real difficulty getting clozapine levels at the moment, just to be aware that you might have to wait a little bit longer than we normally would for the levels. And the other thing to think about is if he's taking lithium, which he's not, but just as a general point, is that fever can obviously cause, and fever and dehydration can obviously cause toxicity, so there's also a need to be monitoring those levels more often. Yeah, absolutely. So there's going to be issues of informing other patients and other contacts, including staff. So again, that's to be discussed with infection control. And I guess what I want to stress is that, we're talking about how to do this overnight. So you're not expected to kind of manage every single thing. There will be some discussions that will have to happen in the daytime. So, that we're trying to focus just on now about kind of what happens overnight. And as I said before about NSAIDs, don't start them. So these are all of the issues, and again, I think we probably might need to think about these in perhaps another tutorial. But again, in the meantime, speak to your consultants about how to manage these situations. It's a really grey area. I think it's going to, I think it's difficult. But obviously, you need to think about whether someone's consenting and has capacity to consent to the medical treatment and the isolation. What do we do if they're refusing these things? And what legal grounds do we have to insist on treatment or containment? And obviously there's kind of the Mental Health Act, there's also the Mental Capacity Act, but there's also a new infectious diseases law that's recently been passed that allows people to be contained and isolated if they've got suspected COVID. So there's various things to kind of think through, probably for another time. And then obviously the issues of PPE needed if someone's needing to be restrained and that sort of thing. And how would the situation be different if he were informal? So again, it's kind of going to at least be started by a discussion with the person about the risks and the benefits, and kind of assessing capacity is still going to be a core part of this, I think. And we will try and cover this in a bit more detail in the coming weeks. I think there's a lot of questions raised that we can't quite answer yet, but hopefully we'll get there with it.
Yeah. So yeah, next. So thankfully though, because we're running out of time anyway, Mr. J is quite anxious, but he's reassured, and he understands the plans. He's disappointed not to be going home, but he's got his iPad and he's got staff around, so he's kind of okay. People are asking about whether we would inform infection control.
Yes, definitely.
Yeah, absolutely.
And Datex.
Yeah, and Datex as well.
Yeah. Okay, so that's where we're up to now. Okay, and because you're all doing a lot of extra work at the moment, we're moving on to your next shift. This is just like a never-ending nightmare, but anyway, so because you're very diligent, you look up Mr. J's notes to see how he's getting on. He's tested positive for COVID now since you last saw him, but he's remained on clozapine and he's been clinically well. He's moved to the COVID ward, but you get bleeped by him saying that he's not looking very well and he's really breathless. He's got respiratory rate of 30, SATs of 70, pulse of 140, blood pressure of 150 on 90, and he's speaking in single words only. Not related to him, but obviously in an older patient it would be a good time to check DNA CPR status. But as he's young, we need to think about what we're going to do next. So, yep, any ideas about what you would do at that point in time?
Good.
Excellent.
Yeah, everyone's
Okay.
saying 999 or 2222.
Yeah. So yeah, absolutely. I think that's depends on your area, and how you do it, depending on whether you're calling for a medical emergency team or if you're calling the ambulance. But basically, you want to be calling for help, and you also want to start emergency treatment for this person. So because he's on the COVID ward, they're all, the staff are already aware that he's COVID positive. They're wearing PPE. They need to get the oxygen and start giving it to him and get the crash bag ready. Need to call for the ambulance and advise them of the COVID status, and you get ready with your PPE again to go in, and then you're advised that he is not breathing. It just goes from bad to worse, really. Sorry, guys. Okay,
Sorry.
Okay, so dangers in this situation is obviously COVID to us and to the other staff. So the latest Resuscitation Council guidance as of the 18th of March says that we need to be wearing FFP3 masks before starting chest compressions. So that is an issue that we're going to discuss a bit further later. In terms of his response, no signs of life. Oxygen running, no change with head lift or chin tilt. No signs of breathing. Again, the Resus Council says don't put your head down and try and listen to someone breathing. Just basically start CPR, because it's, you don't need to do that. Just start, basically. Attach the bag and mask and get the defib ready. So again, this is the Resuscitation Council guidance. It's basically just focused on kind of not giving mouth-to-mouth, early CPR, early defibrillation, and the right personal protective advice. Onward. Yep. And again, wearing the right PPE, and that airway interventions should be done by people who've got training, and if you don't have training, then obviously bag mask is better than nothing. So yeah, and obviously treating reversible causes as we would be doing anyway. Okay, next. So help arrives. Who knows how long that will take. CPR continues, airway management, and he gets taken to hospital and is now intubated and ventilated. So after the CPR, you need to dispose of all the equipment. Again, something to discuss with infection control, and you need to remove the PPE safely. And they also talk about post-resuscitation debrief, which is an important thing to do. I think that's... Okay, so that's the end of the case. Sorry, it's not necessarily a happy ending, but this is a link to all of the guidance that was you know, I guess the important thing to know is that with all of the guidance, it is being updated. So particularly like the BMJ stuff was updated even over the kind of 5 days I was looking at it. So do keep checking back. So these links should still work and give you the most updated slides.
Sure. And just to let you know, I mean, we are recording this. We are going to put it online in case anyone else wants to access it. And we are hopefully going to be running these every week as more questions arise. If you've got any questions, any concerns, any ideas for more tutorials, then Charmin is the person to email about it. If anyone, particularly the guys that are self-isolating at home that might have a bit more time on their hands, if anyone wants to volunteer to run one of these, do give us a shout. That would be awesome.
Yeah. Can I just say thanks so much to Cate and Lynsey for doing this today. I think it's been really, really helpful. Hopefully everyone else has found it helpful, and we'll really look forward to people doing some more work on this in coming weeks. We do have, I think, Paul Galuli listening in, who wants to talk to everybody about, I think, PPE. So I don't know if Charmin can
so
switch.
what I'll do, I'll turn us off, and then
Okay.
Charmin can let Paul talk.
So we'll turn these guys off and hand over to Paul. But thanks very much, guys.
Awesome. And guys, take care of yourself, and you know, be kind to each other. It's going to be a tough couple of months.
No, that's not helped at all.
That's fine, Paul. We can hear you now.
You can hear me now. Okay. Thank you very much for the presentation. That was absolutely superb. So thanks, Juliette, Lynsey, Cate, Shevonne, and Andy. I think this is a really changing time at the minute, and I've been 30 years in the NHS. I never had quite such rapidly changing events over the past 3 weeks. So it's really difficult to catch up. And I understand how anxiety provoking that is on the front line, because what you're being told is constantly changing. I think the main thing for me to say and reassure you is that we want our staff fully protected. We don't want our staff putting themselves at any risk. But unfortunately, what we've had in the past couple of weeks is conflicting things coming from the centre And I wanted just to kind of reassure you on that and where we are just now and what we're planning to do in the future. So in the past 2 weeks, there's two things that have really kept me awake. The first one is PPE. There's been a real problem centrally with the flow of PPE. This is not something that is unique to East London, but has been happening nationally. We were due deliveries of the PPE and they weren't arriving, but eventually the PPE stocks have started coming through. We managed to get 30,000 face masks and gowns from Homerton last night, and another huge arrival has arrived today at Tower Hamlets and is being distributed throughout the services right across the trust. What are the two things with PPE is you have your basic PPE, which is your apron, mask and gloves, but you also have the special masks for when you're in contact with a suspected case of COVID-19, which are the FFP3 masks and the goggles, the gowns and the gloves. These have just arrived today, and what we're doing at the moment is we're putting those into packs and sending them initially to the units that have got positive cases so they can use the appropriate PPE. The next thing we'll do is make sure that they're going out to all units over the next 48 hours, so at least you have one pack on each unit. There should then, over the next day or so, be increased in the number of packs, so you've got at least one pack for each ward, which would be along with the grab bags for the resus, so you have full resus kits. The second thing that's really kept me awake is the conflicting guidance coming out regarding resuscitation. You may have seen a CAS alert, a central alert, that came out from us last week regarding guidance on resuscitation, which only suggested using basic PPE. That certainly was in conflict with the guidance that was coming from the Resuscitation Council. That's why we've changed and managed to get the EP3 through, and the gowns and everything else, so that actually when you're carrying out resuscitation, you should have full PPE available to you, and you should use that if somebody is suspected of having COVID or is COVID positive. I think the presentation has very thoroughly went through the guidance regarding and that. I think lastly, the other thing that's been a major issue is testing of staff. It's something we're really eager that staff get tested, available to them as soon as possible. We're waiting to hear central guidance on that, but it's expected as a ramp up capacity, we should be able to provide testing for staff within the next week or so. I think that's all I can say at the minute. I think the presentation, as I say, was fantastic. I think it's changing as we speak. I think thresholds are also changing for admissions to hospital and transfers of COVID possible patients. And certainly hearing from colleagues south of the river, they seem to be about a week or two ahead of the curve of where we are now with our cases at the present time. But I'm quite happy to I'll have a look at some of the questions coming through on the chat and see if I can answer any of those. People are asking about fit testing with the FFP3s. I think what we have to do is get the FFP3s out. It'd be great if we could fit test them all, but actually what I want to have is access to FFP3s as much as possible. As we improve the amount of FFP3s we have, then obviously what we can do is fit test them as we go along. There's another thing about community teams not having PPE currently. I understand that, and that's why the arrival today of the delivery of PPE should start with the inpatient units and then should go out into the community teams as well. So definitely community teams should have access to PPE in the next couple of days. How can I ask again about how can we stop PPE being stolen from wards? Can I put this back to everybody else and ask you the question? Because I think this is a priority for everybody. I think it's a time when we all have to pull together and work as teams. It's a time when we have to protect each other. I think getting into the situation where we're locking stuff off is not helpful. I think it's a time when we have to trust each other. So I think you are part of that, making sure that the PPE is protected so it's available for everybody, so everyone is safe. Okay, somebody's asking about depots. There's a couple of work streams that are working at the moment to give advice on things like depots. They're also working on advice for clozapine and how we manage clozapine patients in the community and how we manage with blood testing. They're also working on other clinical guidelines as they arise. I agree. I hope that the theft will reduce as actually the supplies actually increase themselves. We've been asked by accommodation providers whether patients can be tested before returning to accommodation. I don't think, as I say, I think part of the problem with the testing has been the capacity for tests to be done. I think one of the things we're trying to get through now is the capacity has increased. That guidance will be changing as we go along. Are we able to test people returning to accommodation providers at the present time? No. In the future, I think that guidance will change rapidly. Okay, what's the leave situation? That depends on your own individual areas. I know certainly within forensic services, they've suspended all Section 17 leave and are treating it on a case-by-case basis. Within acute services, they've reduced it down to leave once a day, but check with your own consultants within that. There's questions about district nurses not giving depots. I'm not sure that's really a question that has to be dealt with locally. The main thing, and I thought from the presentation that I thought was really useful as well, is you are not in this alone. It's really important you speak to your senior, either senior doctors or consultants, and raise your concerns with them. This has to be something that's shared right across teams. Shouldn't be left to you individually to make decisions. A lot of these questions I'm suggesting you take back to your local team and discuss with your local team about how you responded to it. There will be stuff, as I say, there will be guidance coming out that will be trust-wide. That guidance will change over time as we develop and as we move forward. But I think that's all. I'm kind of going over time at the minute. My advice is not conflicting with national advice. That is the national advice at the present time, and that's what we're trying to be compliant with. Actually, the stuff that came out that went on the central alert came from NHS England and was NHS England's advice at the time. The resus guidance we're actually taking up, and that's what we are starting to use now. What I'm hoping should come out within the next couple of days as well is a specific guide from East London on how we carry out resus processes. Now we have Cate here. Visitors, yeah, the visitors have stopped in all services. So initially it was forensic and old age services we stopped visitors. It's now all services visitors have been stopped too, but obviously we'll be taking in an individual basis, particularly as we reach end of life care for some of our service users. We have to look at how we manage that. I think we also have to look creatively, like we've done today, and how we use technology to help support service users having contact with their family. I think I'll take a last one. Localities setting up online meetings for trees. Yeah, I think that's great. Localities are setting up online meetings for trees and consultants to share concerns also. I think this is a really important thing, is actually we're in this together and we have to support each other through the process as well. So listen, thank you very much for coming along today. I will try my best to come next week as well and give you an update on how things are. I'm not too sure if we'll be able to stay for the whole thing. But as I say, it's changing as we speak. Please, above all, can you please keep safe and look after yourself and your family, because only if you're well can you provide care for the service users in our populations that we look after. Thank you.